it's with all my pleasure to start the first session on breast cancer in OncoEgypt today. And I'm very pleased to have this very delighted chairperson co-chairing with me. And we'll call for the first speaker, Dr. Fatma, who is going to give us a lecture on the updates of HER2 positive breast cancer. Professor Dr. Fatma Bounaga is a professor of clinical oncology at Meet Ghamr University. Thank you very much.
صباح الخير. في الأول طبعا بشكر دكتور ريم عماد على الدعوة الكريمة كالمعتاد لتاني سنة في أونكو إيجيبت، وإن شاء الله دايما مؤتمر موفق وناجح كالمعتاد ونقدر نستفيد على recent updates في oncology. Our talk today will about progressive management of early HER2 negative breast cancer. Long back history regarding National Surgical Adjuvant Breast and Bowel Project and changing the mind from a long history above 50 years of clinical trials, changing the mind from just mastectomy to breast conservative surgery following radiotherapy, and era of adjuvant treatment of just endocrine therapy to chemotherapy. Adjuvant CMF node positive breast cancer changes this mind. The result of the last 20 years of follow-up shows significant improvement in disease-free survival and overall survival. Adjuvant endocrine therapy in premenopausal patient with tamoxifen alone halved the recurrence in 50 to the half in the first 4 years, and by third cases in 5 to 9 years. Adjuvant endocrine therapy post-menopausal patient tamoxifen versus aromatase inhibitor, and many scenarios just starting with tamoxifen alone followed by aromatase inhibitor, or switch technique from 2 to 3 years of tamoxifen followed by aromatase inhibitor, upfront aromatase inhibitor. There was no significant improvement in overall survival, but plus increase significant improvement in first year of adjuvant hormonal treatment. Regarding adjuvant endocrine therapy premenopausal patient, and choose best option regarding text and soft trial and adding ovarian suppression, significant improvement in the 8-year survival rate, especially in high risk females. And regarding extended adjuvant endocrine therapy premenopausal female young patient with juvenile-like B disease at increased risk of relapse, so extended adjuvant endocrine therapy will be particularly beneficial in premenopausal women. Regarding new era adjuvant CDK4/6 inhibitors in adjuvant treatment for hormone positive HER2 negative disease, starting with high risk patient defined at more than 4 positive axillary lymph node, or 1 to 3 axillary lymph node with at least one of the following criteria: tumor more than 5 cm, high grade Ki67 more than 20%. Monarch trial showed statistically significant improvement in disease-free survival and statistically significant reduction in risk of development distant metastasis. Adjuvant abemaciclib combined with endocrine therapy previously demonstrated clinically meaningful improvement in invasive disease-free survival and distant relapse-free survival in hormone-positive HER2 negative, node-negative, positive, high-risk early breast cancer, with median follow-up was limited at 15 months, and now more trials about a median follow-up 27 months was performed at request of health authorities. Regarding GAS trial, the majority had higher stage disease and had received prior chemotherapy. So at median follow-up of 31 months, no significant difference in 4-year disease-free survival was observed. Regarding triple negative and chemosensitive and their high response of pathological complete response, patients with triple negative breast cancer who respond well to chemotherapy do just as well as other subtypes of breast cancer. Regarding the recurrence rate in triple negative breast cancer, we can see in patients treated with adjuvant invasive disease were similar in HER2 hormone positive was 7.8 and triple negative was 10.6. Role of taxanes in early triple negative breast cancer regarding other hormone profile regarding breast cancer, significant improvement in disease-free survival regarding taxane arm. ECOG 1199 schedule and type of taxane, weekly paclitaxel showed 10-year overall survival superior in triple negative breast cancer. Is there is a role of density in triple negative breast cancer? Yes, consider those high dense and high risk HER2 negative breast cancer, improved the recurrence rate from 32 to 36.7. Adding anthracycline or non-anthracycline in comparing anthracycline-based arm plus taxanes, non-anthracycline showed non-inferiority of non-anthracycline arm regarding disease-free and overall survival. Regarding ESMO guidelines, sequential anthracycline taxane-based regimen is the standard for majority of patients. In selected lower-risk patients for cycles of anthracycline or taxane-based chemotherapy or CMF in selected patient, non-anthracycline in patient with cardiac complication. Regarding the ASCO guidelines, patients with triple-negative breast cancer who have clinically node positive and at least T1 disease should be offered anthracycline and taxanes containing regimen in neoadjuvant setting. Can any patient with triple negative can be spared to chemotherapy in just small node negative triple negative breast cancer? We can see T1 A 5-year estimate about 53%, T1 B 5-year estimate 90%. Should I offer my patient preoperative therapy? Yes. It's allow time for genetic testing and related impact regarding mastectomy, BRCA mutation, 20% of triple negative breast patient versus 5% in non-triple negative. Can assess a response and the effect provide a better estimate prognosis and possibly escalate therapy if residual disease, aerial introduction of systemic therapy, breast conservation, and improving surgical outcome. What can we offer in neoadjuvant setting for triple negative breast cancer? Impact of delaying initiation time is so important. Less than 3 days should be start treatment. If more than that, we can see it will affect pathological complete response and disease-free survival and overall survival. There is a minimum size required to offer preoperative therapy in patients with triple negative breast cancer. Yes, ESMO guidelines preoperative should be size should be more than 2 centimeters, especially in triple negative breast cancer subtypes. ASCO guidelines, patient 1A to 1B triple negative breast cancer shouldn't be routinely to be offered for neoadjuvant therapy outside clinical trial. In the new challenges, role of adding platinum-based chemotherapy to triple negative breast cancer, immune checkpoint inhibitor, PARP inhibitor, capecitabine. Let's have a quick look. Neoadjuvant brightness study design, we can see in arm A, vilaparib 50 milligram PID plus carboplatin and Taxol. In comparison to carboplatin Taxol, in comparison to Taxol alone, we can see significant improvement in pathological complete response, p-value more than 0.001 in the arm received vilaparib plus carboplatin and Taxol. We can see increase in 10% in event-free survival with impact of adding vilaparib to platinum-based chemotherapy. Patients with pathological complete response had improved event-free survival compared to those without pathological complete response, regardless of BRCA mutation status. Regarding NSC guidelines, we can see the inclusion of platinum agent as neoadjuvant chemotherapy for triple negative breast cancer remains controversial. Several studies have shown improved pathological complete response rate with incorporation of platinum. However, long-term outcome remains unknown. The routine use of platinum agent as a part of neoadjuvant therapy for triple negative breast cancer is not recommended for most patients, including BRCA mutation carrier, but it may be considered in selected patients just as those whom achieving beta local control is necessary. The use of platinum agent in the adjuvant setting not recommended till now. Will immune checkpoint inhibitor work better in early breast cancer? We can see that in the 2 studies, Keynote 502 and MBESON 031, adding pembrolizumab to Taxol carboplatin in comparison to atezolizumab plus nab-paclitaxel. We can see in the both trials significant improvement in pathological complete response, and the most common side effects were tolerated except nausea and alopecia and anemia in the pembrolizumab arm, while in atezolizumab arm was alopecia, nausea, and diarrhea were common side effect. Event-free survival data in MBESON 031 are not yet mature. After median follow-up of about 20 months, median event-free was not reached in either treatment arms. In the early triple-negative breast cancer setting, PD-L1 expression not predictive for event-free survival in Keynote trial, as such as PD-L1 testing not required for pembrolizumab in this setting. Regarding adjuvant treatment after neoadjuvant, according to if residual disease or not, if a patient with pathological complete response for high-risk patient, adjuvant pembrolizumab if already received preoperatively. If residual disease, we can give adjuvant capecitabine 6 to 8 cycle or adjuvant olaparib for 1 year if germline BRCA1/2 mutation, or adjuvant pembrolizumab if pembrolizumab containing regimen was given preoperatively. High risk triple negative breast cancer, we can start with standard NCN, preoperative pembrolizumab plus carboplatin paclitaxel, followed by preoperative pembrolizumab, cyclophosphamide, doxorubicin, or iborubicin, followed by adjuvant pembrolizumab. What can we offer in adjuvant setting for triple negative breast cancer? How to manage patient with residual disease, as mentioned before. Either to give capecitabine for 6 to 8 cycle, we can choose this effect on overall survival and recurrence-free survival. Regarding Olympia study design, germline, BRCA1, BRCA2 mutation, olaparib 300 mg twice daily for 1 year, significant improvement in disease-free and overall survival. Regarding systemic adjuvant treatment in hormone negative, HER2 negative, addition of 1 year of adjuvant olaparib is an option for selected patient with germline, BRCA1, BRCA2 mutation after combination of adjuvant chemotherapy, and to consider adjuvant bisphosphonates therapy for risk reduction of distant metastasis for 3 years in postmenopausal female. In hormone positive HER2 negative, adjuvant endocrine therapy category 1 plus olaparib if germline, BRCA1, BRCA2 mutation. In hormone negative HER2 negative, adjuvant olaparib for 1 year only if BRCA1, BRCA2 mutation, or adjuvant capecitabine or pembro if received new adjuvant before. Consider addition of adjuvant olaparib for 1 year for those with germline, BRCA1 and BRCA2 mutation and triple negative if more than T2 or more than N1 after adjuvant chemo, or residual disease after preoperative chemo. Hormone positive HER2 tumor if more than 4 positive lymph node after adjuvant chemotherapy, or 2 residual disease after preoperative therapy and a clinical stage, pathological stage, estrogen receptor status, and the tumor grade. Olaparib given after combination of radiotherapy and can be used concurrently with endocrine therapy. Triple negative breast cancer and residual disease after preoperative therapy with taxane, alkylate, uncycline based chemotherapy. The standard is capecitabine for 6 to 8 cycles. Nice diagram for early triple negative breast cancer landscape, including germline, BRCA1, BRCA mutation, olaparib, Olympia Keynote, Create X, capecitabine 2017, and high risk HER2 negative early breast cancer with germline mutation. Olympia included the adjuvant treatment, but Keynote new adjuvant and the adjuvant Create X adjuvant with treatment duration about 12 months, with improvement regarding the overall survival, 3 years overall survival and 3 years disease-free survival. But was this statistically difference was not statistically significant. Systemic therapy in 2022 for early triple negative breast cancer, new adjuvant timing is now standard of all but almost node negative. Allow for the escalation of surgery, anthracycline taxane are the standard of care for systemic therapy. Addition of carboplatin in neoadjuvant setting now confirmed based on brightness trial for node or high risk patient. Addition of immunotherapy in triple negative breast cancer approved based on Keynote 522 and some parts of the world, but the question remains which patient truly benefit. Role of PARP inhibitor, BRCA mutant residual disease approved in early triple negative breast cancer and HER2 negative hormone positive patient. New adjuvant timing is now standard for all, but smallest node negative allow for de-escalation of surgery and allow risk stratification of treatment of residual disease. New adjuvant add-on carboplatin, GBAR6 to G6 and the CALPIT trial. The first trial adding non-ligated liposomal doxorubicin to paclitaxel and the carboplatin, and the other arm paclitaxel plus carboplatin plus bevacizumab. We can see here significant improvement in pathological complete response with effect on disease-free survival and overall survival. Platinum add-on increased pathological complete response rate in BRCA wild type. Thank you.
Thank you, Dr. Fatma, for the very informative session. Any question from the floor for the HER2 negative preoperative or adjuvant treatment for breast cancer? Dr. Fatma, I just had a question for you, if you wish. How do you see the implementation of the role of the anti-CDK4/6 inhibitor in a preoperative setting for luminal disease? How do you see the future for that? You know, we don't have yet an approval for anti-CDK4/6 in a preoperative. We have a lot of running trials in that. So what's your insight about that? You can come on the stage, Dr. Fatma, if you wish.
تمام كده كويسه. هو طبعا مؤخرا كل الاير على الادجفانت تريتمنت، فكره النيو ادجفانت هرمونال تريتمنت والهرمون بروفايل واليومينال كلاسيفيكيشن ER BR HER2 KI، ان احنا قد ايه ما قلناش بناخد ديسيجن من غيرهم. حتى في الادجفانت CDK4/6 انهبيتور لما جم يقننوها دخلوا الKI 6/7 ان هو مور ذان 20% دخلوها في الريسك فاكتورز اللي ممكن تستفيد من الادجفانت هرمونال تريتمنت. انا اعتقد ان الفتره الجايه، لان الايرا كلها ان احنا بنحاول نبعد عن الكيمو بالذات ونستغل اليومينال كلاسيفيكيشن بتاع الديزيز، ممكن يعني ميبي نلاقي ترايل جديده بنيو ادجفانت هرمونال تريتمنت زي ما في نيو ادجفانت هرمونال تريتمنت بالاروماتيز انهبيتور الون او التاموكسين بلاز اوفيريان سبريشن ان سيلكتد بيشنت، وتبقى ايرا جديده يعني بحيث ان احنا نبعد عن الكيمو ثيرابي خالص. بس ستيل يعني في وجود الجينيتك تيستنج والبراكا 1 والبراكا 2 ميوتيشن والديفيشنسي، يعني احنا نقدر نعمل كل حاجه، اعتقد ده ممكن ياخد تايم. لكن الايرا الجايه انا واتمنى ان المبادره تسبورت ده مستقبلا، يعني ان الحالات الهاي ريسك فعلا اللي تقدر تستفيد من الادجوفانت CDK4/6 انهبيتور، ان احنا ممكن نضيفه في التريتمنت حالات الهاي ريسك بريمينوبوزال هاي ريسك بيشنت اكتر من 4 بوزيتيف ليمف نود KI اكتر من 20% الهاي جريد، ونشوف الريزلت دي هل ممكن فعلا تفيدنا ولا لا.
Thank you very much. So I would expect, in view of the benefit of anti-CDK4/6 inhibitor in a metastatic setting versus chemotherapy, with the definitive improvement in pathological, in response rate, in disease-free survival, and in overall survival for some, like ribociclib, I expect that in a neoadjuvant setting, there would be a superiority of this agent over chemotherapy, specifically in the luminal. We just needed signature, a molecular signature for whom are going to benefit more from this rather than chemotherapy in a preoperative setting. So thank you very much, and you can present the next.
Okay, thank you very much, Dr. Fatma, for your lecture. It was a nice one, actually. And I have the pleasure to present my colleague, Professor Ahmed Eldabawi, Tanta Cancer Center. He's going to present antibody drug conjugates in metastatic triple negative and HER2 low breast cancer.
Thank you. بسم الله الرحمن الرحيم. Triple negative breast cancer is the term used to describe breast cancer that lack estrogen and progesterone receptor expression and don't overexpress HER2 and associated with an aggressive clinical course and poor prognosis. Despite the great effort to classify triple negative breast cancer and the wide landscape of biomarker development, only PD-L1 is applied in clinical practice as a validated biomarker for response to immune checkpoint inhibitor, as anti-PD-L1 itezolizumab plus nab-paclitaxel in tumor express PD-L1 1% or more, and anti-PD-1 pembrolizumab plus chemotherapy, either with nab-paclitaxel, paclitaxel, or gemcitabine carboplatin in tumor with combined positive score 10% or more. Also, germline BRCA mutation in HER2 negative metastatic breast cancer are target for PARP inhibitor olaparib and talazoparib. For most triple negative breast cancer, PD-L1 negative and germline BRCA wild type, chemotherapy remains the standard treatment. However, specific data concerning metastatic triple negative breast cancer treated by chemotherapy are missing. Combination chemotherapy could be preferred in case of imminent organ failure, metastatic triple negative breast cancer. Taxane-based regimen are the only standard of care in first-line therapy in patient progress after anthracycline based non-taxane adjuvant chemotherapy regimen. There is no standard approach for patients required second or further line chemotherapy treatment. Over the past few years, there have been an emerging interest in antibody drug conjugates for the treatment of refractory tumor, including metastatic triple negative breast cancer. The most advanced ADC in clinical development for metastatic triple negative breast cancer is cestuzumab govitecan, targeting trophoblast cell surface antigen 2, TROP2, expressed in majority of triple negative breast cancer. Cestuzumab govitecan is a humanized anti-TROP2 antibody that targets the active metabolite of irinotecan to self-express TROP2, composed of anti-TROP2 antibody SN38 payload, which is the active metabolite of irinotecan, and linker for SN38. It also has
different from the classic antibody-drug conjugate by the presence of bystander effect, as in acidic tumor microenvironment, SN38 is released from anti-TROP2 antibody and diffused to neighboring cell, even before the internalization between TDX and anti-TROP2. In the ASCENT trial, which is a phase 3 trial, patient with metastatic triple-negative breast cancer with 2 or more prior chemotherapy with no upper limit, with permitted brain mets if stable for more than 4 weeks. Also, about 30% of these patients was non-triple negative in the first presentation of the disease before being metastatic, which underscores the importance of biopsy of tumor when recurrence is occur. Sestuzumab govitecan 10 mg per kg IV on day 1 or day 8, or physician choice of single agent chemotherapy with primary endpoint progression-free survival by the blinded central review in patient without brain mets. This trial, in ASCENT trial, met its primary endpoint by improvement of median progression-free survival from 1.7 months to 5.6, with hazard ratio for death or progression of 0.39, and also improve median overall survival by improvement of survival from 6 months to 12 months. Survival outcome numerically better with SG versus chemotherapy in patient with high medium TROP2 expression, but small number with low TROP2 expression limited the ability to draw conclusion about the correlation between the expression of TROP2 and the effect of drug. Objective response rate was improved from 5% to 35% with chemotherapy, as is expected from the active metabolite of irinotecan. There's a common grade 3 or higher adverse event, including neutropenia, leukopenia, diarrhea, and anemia, and febrile neutropenia. Also, the reaction, a total of 3 deaths in each group was attributed to adverse events, with no deaths were deemed related to SG treatment. In subgroup analysis of patient with brain metastasis, SG have a median, patient received SG have a median progression-free survival of 2.8 compared to 1.6 months with chemotherapy, and overall survival of 6.8 months compared to 7.5 months. The analysis of health-related quality of life based on the ASCENT trial concluded that SG was generally associated with greater improvement and delayed worsening of global health status and physical functioning and fatigue and pain compared with chemotherapy. However, SG was inferior regarding change from baseline for nausea, vomiting, diarrhea, but non-inferior for other URTC, QLQ, C3 domain. In conclusion, SG is now approved for patients with unresectable, locally advanced triple-negative breast cancer or metastatic triple-negative breast cancer who have received 2 prior systemic therapy, including at least 1 for metastatic disease. Neutropenia was high in patient received SG with precaution, with hold if absolute neutrophil count less than 1,500 on day 1 or less than 1,000 on day 8. CSF and dose reduction for grade 4 neutropenia lasting for more than 7 days, or grade 3 neutropenia, suspect UGT1A128 genotype or polymorphism, prolonged neutropenia, and response to treatment with prophylaxis by short-acting GCSF from day 2 to day 4, or long-acting alone on day 9. The second part is antibody-drug conjugate in HER2-low metastatic breast cancer. For many years, HER2 positivity was defined by the binary classification to be scored by immunohistochemistry 3+, or HER2 score 2+ was amplified by in situ hybridization, and anything else HER2 negative. The newer classification of HER2 negativity expression, including immunohistochemistry and HER2-low, included immunohistochemistry 1+ and immunohistochemistry 2+ with in situ hybridization negative. MYC tumor with HER2 low are attractive targets for the newer generation of HER2-directed ADC with improved outcome. Is HER2 low breast cancer is a new subtype? No, HER2 low breast cancer is not a unique subtype, but it is a targetable subgroup. About 2/3 of patients with hormonal positive disease are HER2 low, and 1/3 of triple-negative breast cancer are HER2 low. There is a marginal difference in gene expression between HER2-0 and HER2-low. Triple-negative are mostly basal-like at PAM50 regardless of HER2-low expression, and the hormonal positive are mostly luminal at PAM50 regardless of HER2-low expression. However, slightly more basal-like among the hormonal positive HER2, which are likely the ER-low tumors. The classification of therapy of HER2 breast cancer may be divided to HER2 target monoclonal antibody or tyrosine kinase inhibitor or HER2 targeted ADC. The trastuzumab deruxtecan TDXD composed of anti-HER2 with highly potent topoisomerase inhibitor payload, and also the linker TDXD bind to HER2, TDXD internalized, linker cleaved releasing topoisomerase inhibitor 1 and enter nucleus, and also it is membrane permeable, result in bystander effect. In Destiny Breast 04, which is a phase 3 trial, included patient with HER2-low and resectable or metastatic breast cancer with 1 or 2 prior line of chemotherapy in metastatic setting, and at least 1 endocrine therapy if hormonal positive, was randomized to in 2-to-1 ratio to either TDXD 5.4 milligram per kg every 3 weeks or chemotherapy. The primary endpoint was progression-free survival in hormonal positive patient population. In patient with hormonal positive disease, median progression-free survival improved from 5.4 to 10 months, and progression-free survival in all patients was increased from 5.1 months to 9.9 months. Also, overall survival increased from 17.5 to 23.9, and in all patients, also there is an improvement of median overall survival. In the exploratory analysis of progression-free survival in hormonal negative HER2-low cohort, which was a small number of patients, chemotherapy TDXD improved from 2.9 to 8.5, and also overall survival was improved. The progression-free survival benefit of TDXD over chemotherapy was present in a predefined group of patients, such as prior CDK4/6 inhibitor, or regardless of immunohistochemistry, and also if there is a visceral disease at baseline or not. In ER-low tumor, TDXD significantly improved progression-free survival and overall survival compared with chemotherapy, increased overall survival and progression-free survival. Nausea and fatigue and alopecia and vomiting and neutropenia and anemia and thrombocytopenia was higher in TDXD, with higher grade 3 adverse event, neutropenia and increased and leukopenia in chemotherapy. The most important adverse event of special interest, which are drug-related ILD pneumonitis, which is present about 12% of patients. Also, ejection fraction decreased and the cardiac failure. Lung toxicity is frequent with oncology drug, include taxane and anthracycline. ILD is characterized by ineffective gas exchange due to alveolitis and disrupted alveolar structure, and may be related to target-independent uptake of payload in immune cells and bystander effect of released by payload. The most important thing to monitor the patient and urge patient to immediately report cough and dizziness and fever, and also exclusion patient with previous symptom of ILD and confirmed by high-resolution CT or blood culture or CBC or bronchoscopy or arterial blood gases, and rule out PSCB infection, and those interruption for asymptomatic patient, and for grade 2 to 4 symptomatic patient, and permanently discontinue the treatment, and initiation of corticosteroid, together with 0.5 milligram for grade 1 or 1 milligram per kg prednisolone for grade 2 or more. If resolved in less than 28, maintain the same dose. If resolved more than 28 days from onset, reduce one dose level. Neutropenia is less expected with TDXD. In summary, TDXD is the first HER2 target therapy to demonstrate improved efficacy in HER2-low metastatic breast cancer, with potential improvement for about 50% of all patients with metastatic breast cancer in this setting. The FDA-approved TDXD for patients with unresectable or metastatic HER2-low breast cancer who have received a prior chemotherapy in metastatic setting or developed disease recurrence in less than 6 months or equal completing adjuvant chemotherapy. Another investigational HER2 targeted ADC, trastuzumab deoxycycline, which HER2 antibody with the same amino acid sequence with trastuzumab with alkylating agent payload and have also bystander killing effect. The most commonly adverse event are eye or respiratory disorder. Another TROP2 antibody drug conjugate in triple negative breast cancer are datopotamab deruxtecan, which is the differentiated TROP2 directed ADC designed with 3 components, anti-TROP2 and linker and topoisomerase 1 inhibitor. Dato-DXd has demonstrated high encouraging anti-tumor activity with manageable adverse event in triple negative breast cancer and is now investigated in hormonal positive HER2 negative breast cancer. In the today roadmap for hormonal positive HER2 low or HER2 zero, trastuzumab deruxtecan are used in HER2 low as a second or third line chemotherapy, and in HER2 zero, cystozumab govitecan may be used as from third to fifth line treatment. In summary, next generation EDC is still new and evolving space. SG is approved for patients with unresectable locally advanced triple negative or metastatic triple negative who have received 2 prior systemic therapy, including at least 1 for metastatic disease, and also it is used as a second line in hormonal positive metastatic disease. HER2-low breast cancer is not a unique subtype but targetable subgroup. TDXD is the first HER2 targeted therapy to demonstrate improved efficacy in HER2-low, clearly understanding mechanism of resistance and identifying novel biomarker and sequencing studies such as topoisomerase after topoisomerase will be key optimizing and personalizing EDC therapy in the future. Thank you.
Ahmed Debawi, you have made it very clear. Thank you very much for the very illustrative presentation. Well, and any question from the floor for Professor Ahmed? Okay, he had made it very clear that the new generation of antibody drug conjugate have a higher affinity for the HER2 receptor, despite that the older generation did not have. So we can use it in HER2 low. But I have an observation, which would be a very simple observation. You might give me your insight. In the first trial of the new antibody drug conjugate, trastuzumab deruxtecan, we have even witnessed response rate in HER2 zero, 29%, zero, not even HER2 low. Do you have any explanation for that? From my side, I believe it's a chemotherapy part. It's not the antibody drug conjugate. But it was a fascinating observation that even we have new trials going, how low can we go? Yeah, it's ultra low, exactly. So these are the very new trial, which is surprising data. So hey, maybe one day we'll go to HER2 zero, we don't know. We have some trial, which is ultra low, like you just said. How low can we go? So thank you very much. It was very clear and very illustrative. Thank you. So it's with all my pleasure now to move to the younger female counterpart with breast cancer and the fertility issue and the pregnancy. It's a very stressful discussion at the clinic for patient and the younger counterpart thinking about preservation of fertility. And I would, with all my pleasure, I would present my co-chair, Dr. Hanan Azzat, the professor of clinical oncology in NCI, to present for us all the data about fertility issue and pregnancy in young females with breast cancer. Thank you very much.
صباح الخير. الحقيقة I have the pleasure to be today with you in the Ministry of Health conference. Actually, one of the new conferences, but however, it's an interesting one, and it's actually covering the whole of the country. I was thinking what to be talking about today, and we are discussing a lot of topics about how our guidelines and how to treat our patients. But I found that there is a topic which is very important, very interesting. I feel it a light topic compared to the topics full of evidence, but it's very important because, as Dr. Tamer was telling, that this is everyday practice, everyday discussion in our clinics. And I was just talking with Dr. Sarah before our sessions, and her comment when seeing our patients is that we are usually seeing younger patients than you usually is seen outside Egypt. So this makes it more stressful on us. And I believe that in our practice, we have, in breast cancer patients, more than 50% of the patients are premenopausal. And actually there was a review article which was published this year by Professor Dr. Hamdi Abdulazim and his team about our profile in cancer breast. And the main comment was that we are having more ladies in young age having breast cancer and also advanced disease at presentation. So this is why I was inclined to choose this topic. And actually I changed the topic before the conference by a few days because I'm feeling that it's very important to hear this today, actually. So, what I want first to stress on is that one of the commonest malignancies that we are seeing during pregnancy is cancer breast, followed by cancer cervix. So it's a great problem. We have 1 in 3,000 pregnancies can be complicated with breast cancer. So it's an important topic. We are seeing this maybe 2 or 3 times every year in our practice, but once seeing it, we usually need to stop and to think so much because we are not seeing commonly. So today I'm trying to sum up the evidence and how are we going to deal with this group of patients. First, is there any molecular subtype differences between patients who are pregnant and those who are not? Actually, the evidence says that there is no difference. We have the same distribution of the luminal types between patients who are pregnant and patients who are not pregnant. Still, the luminal B subtype is prevalent, more prevalent in all the groups of patients. So there is no difference in the molecular subtypes. So my advice today for all of us, actually, when we are seeing a pregnant patient with breast cancer, we should be cautious and we should be sticking so much to the guidelines. We can ask for the advice if we are not sure, this is not a problem. And if possible, we can get the patient treated in a more experienced center if we are working in a faraway place. This is very important. Actually, I find this website also that was launched this year. It's actually a helpful site when we want to check our knowledge about how to treat patients with breast cancer together with pregnancy. So we can also use this website as a helpful site. So the question that once we see a patient who is pregnant coming with breast cancer, should we continue pregnancy or should we terminate the pregnancy? And this is the question that we are going to answer today in detail. So first of all, when we are seeing a patient with breast cancer, so what to do to diagnose this patient? So what is allowed and what is not allowed, this is very important to know. First of all, we have the golden rule that ultrasound is completely safe for this group of patients. So the first and the most important thing we can do is an ultrasound to the breast in order to check the site of the tumor, the size, the stage of the tumor, and the axillary lymph nodes. So can we go for a mammography or not? Actually, there are a few trials telling that mammogram is still safe in this group of patients, especially in the first trimester, with shielding, of course. Why? Because when we calculated the dose of radiation that the patient is exposed to during pregnancy, it came to be about equivalent to about 7 days of the background radiations we are exposed to every day. So this is not harmful. So we can go for mammogram, especially in the early pregnancy with proper shielding, because usually the breast is far away from the small uterus at the early pregnancy, but it's not that much advised. We can do this if we need, if a patient is having a dense breast and if it's difficult to get data we want with an ultrasound. So what about the X-ray and the low-dose CT scan? We can also go for these two modalities still in the first trimester, because still the uterus is very small and it's away from the breast and we can shield it properly. So we can do this if we need.
But however, in the second and third trimester, it's not advised to go for these modalities. Instead, we can use the diffuse weighted imaging MRI, which is actually safe without, of course, contrast. So what about the abdomen? As we all know that examination of the liver is very clear and ultrasound can give us data which are enough. Also, we can use diffuse weighted imaging MRI for the bone, for the brain, for the whole body, even if we want. Of course, bone scan and PET scan are completely cannot be used during pregnancy. So this is the first. We talked about the diagnosis, what to do and what not to do. The second important point is what to give and what to postpone, and what we can do and what we cannot do. Surgery, first of all, surgery can be done in all the trimesters, in the first trimester and along the whole pregnancy. There is no problem to go for surgery. What about radiotherapy? Actually, it's better not to go for radiotherapy during a pregnancy. There are some data on giving radiotherapy in the first trimester, still for the same reason that the uterus is small and it's away from the breast. However, there is nothing urgent to give radiotherapy during pregnancy. It's better to be postponed after. So what about our daily practice with the chemotherapy? As we all know that the chemotherapies are usually small molecules, so they can cross the placenta easily. That's why we are not giving any chemotherapy during the first trimester. It's completely prohibited to give any chemotherapy during the first trimester. However, in the second and third trimester, we can use some chemotherapeutic agents I'm going to discuss with you later. Endocrine therapy, it's better not to give any endocrine therapy during pregnancy because, as we all know, that it has a high teratogenic effect. And about the targeted therapy also, it's better to be postponed after chemotherapy, after pregnancy, sorry. So in summary, surgery can be done all over. Chemotherapy can be given starting from the second and third trimester. Everything else is better to be postponed after pregnancy. So what I'm going to stress on now is the chemotherapy because I think most of us are medical oncologists. So in the first trimester, as we all know that the rate of teratogenicity or major malformation is about 14%, which is actually a high rate. So this means that we are not going to give any chemotherapy to the patients in the first trimester. So what about the second and third trimester? The rate of major malformation is about 3%. So we can give actually chemotherapy in the second and third trimester. So actually this table is showing us what percent of each of these chemotherapeutic agents can cross the placenta. So if we look, you will find that for the taxanes, ibuprofen has about 4% ability to cross to the placenta. Doxorubicin is having a higher probability, which is 7.5. That's why when we are choosing between them, it's better to go for ibuprofen than doxorubicin. For the taxanes, you'll find that Taxol is having about 1.4% to cross the placenta. Paclitaxel, we don't have enough evidence, so if we are choosing, it's better also to go for paclitaxel. Cyclophosphamide that we are using so much, Bardoxolone is having a high possibility to cross the placenta, about 25%. So this is how can we choose about the regimens? So as I told you, if we are going to use an anthracycline-based regimen, better up to ibuprofen, not doxorubicin. We can also use doxorubicin, but ibuprofen is better. And if we are going to give taxanes, we are going to opt to paclitaxel more than docetaxel. Also, we can switch giving the taxanes first and then giving the anthracyclines according to the gestational age, because as you saw before, that taxanes have a lesser probability to cross through the placenta. What about the dose-dense regimens? Dose-dense regimens can be used actually in pregnancy, but the problem is that we need to use G-CSF. And as you see in the table to the left, that we don't have enough evidence about the safety of G-CSF during pregnancy. The number of patients who are receiving dose-dense chemotherapy are only 10. This is the biggest trial, so the data about G-CSF use is not that mature. So it's not completely prohibited to use dose-dense, but it's better to go for the standard regimens. This is for chemotherapy. Okay, so the rules that we are not going to administer any chemotherapy during the first trimester. We are going to use the standard protocols. We are going to calculate the dose of the chemotherapy according to the actual body weight of the lady we are seeing. We are going to maintain dose intensity as much as possible. We are not going to increase or decrease the dose per meter square, and we are going to discontinue the chemotherapy. This is very important. At week 35, if we are giving every 3 weeks regimen, and at week 37, if you are giving a weekly regimen to give time for the recovery of the white cell count. So what about the targeted therapy? Actually, in breast cancer, we are using the monoclonal antibodies like the trastuzumab. And as we all know that trastuzumab is a big molecule, or the monoclonal antibodies are usually big molecules. So they are not able to cross the placenta, especially in the early trimester. So if we look here at several trials showing the teratogenesis effect of trastuzumab, we'll find that the lines in blue are the ones. The lines in blue are showing that there is no teratogenic effect, while the lines in red are showing that there is a complication that can happen to the baby. So this means that during the first trimester, trastuzumab is not able to cross the placenta, so it's not going to cause much deformity or much effect on the oligohydramnios to the patient. However, this doesn't mean that we can give the patients proactively trastuzumab in the first trimester, but a clinical scenario that we are seeing in our clinics every day, that a patient who is on trastuzumab and she discovered that she is pregnant, she is early pregnant, so should we terminate the pregnancy or should we continue? The answer is we can continue the pregnancy as long as we in the first trimester, because in the first trimester, trastuzumab doesn't have the ability to cross the placenta. So this is very important to be knowing. So after the first trimester, in the second and third trimester, at that time, as we all know that the HER2 is needed for the formation of the fluid around the baby. So the destruction of the HER2 usually causes oligohydramnios. So the main complication that we see in pregnant ladies who are receiving trastuzumab at the second, third trimester is oligohydramnios. So that's why we are not advising to give any trastuzumab in the second and third trimester. So as regards the monoclonal antibodies, as I told you before, in the first trimester there is no problem to the fetus, but don't give proactively, only just when seeing a patient who is coming to you in the first trimester and she was receiving trastuzumab accidentally, don't tell her to terminate the pregnancy, just explain for her, and never give in the second and third trimester. For the pertuzumab, there are no much data about it, so I don't have actually something to tell you, solid to tell you about it. For the TKI tyrosine kinase inhibitor, like the Tykerb and something like this, actually they are dealt with like the chemotherapy because they are small molecules and they can cross the placenta, so we are dealing with it the same as we are dealing with the chemotherapy. So what about the PD-L1 the immune therapies? Actually, we all know that it can disrupt the maternal fetal immune tolerance, so that's why it's not advised to give PD-L1 agents for a pregnant lady, because probably it will cause abortion. So what about hormonal treatments? As we all know that tamoxifen has a clear teratogenic effect, so usually we are postponing the hormonal treatment after the end of pregnancy. For the supportive treatment, metoclopramide and serotonin antagonists are safe. Ranitidine and proton pump inhibitors are also safe. For the steroids, methylprednisolone, prednisolone, and hydrocortisone are safe. However, dexamethasone should be limited. GCSF, as I told you before, we don't have enough data. We are using it, but we don't have actually solid evidence for the iron and iron compounds. It's better to use ferric carboxy maltose for these patients, and of course low molecular weight heparin is safe also. Okay, so this we've been discussing. So what important thing also I want to know today is that the problem with the pregnant lady is not the chemotherapy. The problem with the pregnant lady and the baby actually is the time when we terminate the pregnancy. So if we look at these two curves, the curve to the right is showing the effect of and the number of chemotherapy on the cognitive outcome of the patient. And just to explain, when the cognitive outcome is less than 85, this means that the baby is actually affected so much. Okay, so if you look here, that number of chemotherapy does not affect the cognitive outcome of the baby. However, if we look at the gestational age, we'll find that those who terminated pregnancy before 36, usually this affects the cognitive outcome of the baby. So it's very important to make sure that the lady gets delivered as long as possible, after 36 or 37 weeks. The one thing I want to discuss with you is pregnancy after breast cancer. So should we allow our ladies to get pregnant after breast cancer or not? This is a very crucial question. And actually those ladies are usually having a problem in fertility. So this makes the incidence of pregnancy after breast cancer is low. And another thing is that when some of the professional doctors who are working in the field of breast cancer are usually inclined not to ask to let the lady get pregnant. And this was a survey that was done actually. And if we look at the results, we'll find that we have about 1/3 of the doctors they are not they are disagreeing to allow their ladies to get pregnant, and in the BRCA positive, they are about half the doctors. Usually, they are not feeling okay to approve the lady to get pregnant. So what I want to tell you is that this belief is not correct, because these are all the retrospective trials we are having on this entirety, and we will find that pregnancy does not affect the outcome of the ladies with breast cancer. And if you look at the curves here, we'll find that the disease-free survival and overall survival in the ER positive and ER negative, and even in the BRCA positive patients, is not affected actually by pregnancy. So this means that pregnancy doesn't have an impact on the survival of the patients. This is very important. One important trial is the only prospective trial which was published this year, which we call Pregnancy Outcome and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer, a positive trial. We will give us quick insight. Actually, the time is over. Just give me 3 minutes. Okay. So this is the trial where patients on hormonal treatment were allowed to interrupt the hormonal treatment after 18 months of treatment. Then they give them 3 months washout, and then they are allowed to be away from hormonal treatment for up to 2 years in order to get a chance to get pregnant. And then after that, the data were analyzed, and the follow-up was about 3.5 years. And if we look here at the disease-free survival of these patients, the disease-free survival regards the recurrence, the local recurrence, we'll find that there was no difference between the patients who interrupted their treatment to get pregnant and all. There was another group of patients who were made like a control, so there was no difference. And if we look at the distant recurrence, we find also that there was no difference in the rate of distant recurrence at 3.5 years. Just keep in mind that our follow-up here was only 3.5 years, so it's not a long time, a long duration of follow-up. Okay, so in the positive trial, nearly 3/4 of women had at least one pregnancy during these 2 years of interruption. This means about 70% of the patients. More than 40% were using assisted reproductive technique. Percentage of patients who became pregnant were about 53%, and this is a big number. And finally, I want to tell you that the positive trial also proved that pregnancy after treatment for breast cancer or after interruption of hormonal treatment does not have a bad impact on the outcome of the patient. Maybe at least in the first 3.5 years that are followed up in the trial. So last point I want to just to highlight, because for the sake of time, is if we are going to make the patient pregnant, how long should be away from our treatment? For the chemotherapy should be stopped for at least 1 year before trying pregnancy. For tamoxifen, we should stop tamoxifen 3 months before allowing conception for the patient, and for trastuzumab, we should stop it 7 months before allowing conception. For the new agents, actually, we don't have solid evidence, but we can stop the immunotherapy for 4 to 5 months. Abemaciclib can be stopped for about 3 months, olaparib for about 1 month. So this is very important to be knowing when to tell the patient she can get pregnant and for how long should be stopping the treatment. Thank you very much, and sorry for being slightly out of time. Thank you very much.
Very much, Dr. Hanan. You made it very clear. Any question from the floor for Professor Hanan about fertility and young? No, we have a question here. Great.
Thank you, dear Professor Hanan. You just make it very clear and very evidence-based, very nice lecture. I have few questions, 2 questions in the very rapid. Number 1, for those, as you elaborated, those who discover pregnancy, and they are not very common, but not very rare, to discover the pregnancy in the first trimester while she is on TAM or Herceptin, and you elaborated, we have some reassuring data to continue pregnancy. So what about the Kadcyla, if the patient is on T-DM1? The second question, for the positive trial, would you consider the interruption and to follow the positive trial in our patients locally advanced? Thank you.
Thank you, Dr. Hagar. And actually, I have a note that Dr. Hagar, the one who made me interested in this topic, actually. So actually for Decapsila, I think we should be dealing with it like we are dealing with the trastuzumab, because actually Decapsila is a trastuzumab with chemotherapy, so we are going to follow the same guidelines if interrupted in the first, but actually we have an element of chemotherapy, Bardo. It's actually a tricky question, but we can, if in the first trimester, we can explain for the patient and then we can proceed. For the positive trial, actually, till now, I'm not that comfortable for making this, but all the retrospective evidence and the evidence from the positive trial till follow-up of 3.5 years are telling that there is no harm for the baby and no harm for the lady. So for me, if the patient is doesn't have any children and she's very young and she's very eager to go for pregnancy, I'm going to do, actually, with close follow-up. Okay, thank you.
Thank you. Am I allowed to ask a question too? So thank you for such a great talk and some really, really important messages. But I think, as we know, between us as professionals, we have to give the patients confidence that they could have a pregnancy. And so for me, your slide that was very telling was the one of what the doctors feel. You know, if it was your sister, if it was your mother, would you encourage them to have a pregnancy? And I agree with you that we all feel nervous about it, but the evidence is that pregnancy after 2 years after a breast cancer does not impact long-term survival. And equally that the ovarian stimulation that's used during fertility treatment, possibly just before you give your chemotherapy, I know my colleagues are nervous about it, but again, the evidence is that it doesn't have an impact on long-term survival. But the evidence around pregnancy-associated breast cancer, I've given a talk on it myself, is really very confusing, very poor, very small numbers, different definitions. Is it actually during the pregnancy? Is it within 1 year of pregnancy? And so I think I would really encourage you as a group who see many, many of these patients, because you have a younger population than I would have in the UK, please gather some evidence, do the trials.
Thank you, Professor Sarah. Actually, we were just talking before the session started that we need to collect our data about pregnant ladies, because actually you are having a good number. And actually, you're going to do it, inshallah. Okay. Thank you.
Hanan, just a very common question and insight that we need to discuss with the patient. The majority of your breast cancer are premenopausal in Egypt. The majority are receiving tamoxifen in an adjuvant setting. And tamoxifen does not hamper fertility and does not hamper pregnancy. What if a patient comes to you after 2 years of ending of the adjuvant chemo, she is on tamoxifen, and she comes to your clinic and she told you, oops, I'm 10 weeks pregnant on tamoxifen, and it was an unplanned pregnancy. What would be your advice for such a patient?
Actually, for tamoxifen in the first trimester, still we have data that it cannot cross the placenta. So if you encounter a patient who was on tamoxifen and discovered pregnancy in the first 14 weeks, actually you can proceed to continue the pregnancy, not to terminate until, yes, you can continue for the first 3 months. And one important point, actually, I didn't have time to tell it, is the use of LHRH analogs for these patients as a way of, not a way of fertility preservation, but it's a way for, like protection of the ovary. It's very, very effective. And there is about 15% improvement in the ovarian function when using LHRH analogs with our hormonal treatment in young patients for the sake to protect the ovary, and even during the adjuvant chemotherapy and in the metastatic setting. This is very important.
Thank you very much, Dr. Hanan, for as a fertility specialist, I'm an assistant professor in obstetrics and gynecology, and I'm concerned about the fertility preservation in onco patients. So the other half of the lecture, which is truly important, and I think it has to be more elaborated in a longer talk. So we have multiple options for women with breast cancer who will undergo chemo or radiotherapy before attempting chemo or radiotherapy. like oocyte cryopreservation, embryo cryopreservation, ovary cryopreservation. We can do all of these before starting chemotherapy. And in the past years, usually the medical oncologists try to push us to end up the stimulation protocol very early. And we have now the random start protocol. So we can start ovulation induction and retrieving the oocytes from the girls or from the mothers just in 15 days. And then we'll discharge the patient to her chemo or radiotherapy. Another comment is that BRCA patients have unfortunately, they have poor response to the ovulation induction medications, and so they may need more than one cycle for ovulation induction in order to have more embryos to freeze or more oocytes to freeze. This is my comments for that, and thank you very much for your nice lecture.
So actually, I have the pleasure to introduce my dear colleague, Professor Dr. Tamer El-Nahas, Professor of Clinical Oncology at Qasr Al-Aini School of Medicine. Dr. Tamer is going to talk to us today about neoadjuvant immunotherapy in breast cancer, a very interesting topic. Thank you, Dr. Tamer.
Thank you. Thank you very much. So we are going to thank you very much for all the organizing committee of Onco Egypt for inviting me for this very interesting talk and this very interesting session. Thank you, Reem, and thank you for all your team of the organization for developing such a nice scientific model in Egypt. So I would like first to thank all my chairperson, Professor Sarah, Professor Hanan, Professor Mohammed, Nirvana, thank you very much. Would you give me 20 minutes instead of 15? It's okay? We have time. I know you have the opening ceremony in a few minutes. So we are going to talk about immunotherapy in triple-negative breast cancer, the bad subtype, the bad subtype of breast cancer. So can we make it an interactive session? How many medical oncologists are here in the yard? I'm a medical oncologist. How many? Okay, so there's a few. How many surgical oncologists are present? Okay, very good. And how many radiation oncologists? Okay, so very good. Okay, So, you know, immunotherapy have evaded the land of breast cancer, and it started with triple-negative breast cancer, and hopefully, you know, I think the information is very clear for you that it does not constitute the majority, hopefully. It's a bad subtype. It constitutes between 15 to 20% only, so that's the good news. And why it is a bad subtype? Because as you can see in this three curve across the board, that in all stages of breast cancer, the inferior survival is for triple negative. Stage 2, high recurrence, stage 3, and you can see the difference in stage 4 on the right side. A big difference between the other subtype. The worst subtype, the black one, the black curve is for triple negative breast cancer, a really bad subtype. And why is it bad? Because of this curve, you can see the blue lines and the recurrence rate in the first 3 years extremely high with the blue for the triple negative. If you are following your patient with triple negative breast cancer, you need to strict your follow-up in the first 3 years because this is the highest incidence of recurrence. But if you're following luminal, you need probably a more and a longer follow-up because the luminal have a long time, a late recurrence later on. That's why, in view of the worst overall survival and in view of the high recurrence rate of this triple negative, we had many efforts, many adds-on to reach that, to reach this red line. What is this red line? These red lines are the patients who are achieving a pathological CR before surgery. Look at the difference here in event-free survival, the red line and the blue line. So what is our aim? Is to reach a pathological CR. We need to reach this red line in terms to be implicated on the survival. So what are the adds-on, what are the efforts that have been made during the last 2 decades? First of all, the dose-dense AC, intensifying treatment, addition of platinum, and finally addition of immunotherapy. But what if you are in the blue line, the bad one? the patient who did not get a pathological CR at the time of surgery. So you need additional therapy, capecitabine, the CREATE-X trial, and olaparib, the PARP inhibitor. So we have adds-on in a neoadjuvant setting and adds-on on an adjuvant setting to reach a better survival for the patients. You know that the dose-dense AC have been tried since many, many, many years, by the way, and the CALBG group was the first group to test dose-dense AC. What's the difference between conventional AC and dose-dense AC? Dose-dense AC is trying to strike the cancer cell at an earlier phase of repair and repopulation after the harm of the DNA damage of the chemotherapy. The triple negative have a very quick response to repair itself, so you try to give the chemo a little bit earlier to prevent this repair and this repopulation. And look at the p-value here, every 2 weeks AC versus every 3 weeks. We know that every 2 weeks is more harmful, but it's more beneficial. And the meta-analysis have shown that the recurrence rate and the 10 years gain in survival was much higher in the dose-dense AC. So dose-dense AC became one of the standard and the cornerstone treatment of triple-negative breast cancer. And this, by the way, have been recently visited by an Italian physician, scientist, Del Mastro. Del Mastro have tried to check what is the value of dose-dense AC, not only in triple-negative, but in all breast cancer subtypes. So he got all the subtypes of breast cancer to dose-dense versus conventional. And what did Del Mastro found? He found that in the overall population, luminal, HER2-positive, triple-negative, we have a survival benefit of a delta of 7%. I know that most of you now want to check what is the difference between the different subtypes. Look at that curve. This is very interesting. The triple negative, the delta is 12. But even in the luminal subtype, the delta is 7%. So there is still benefit of those dense even in the luminal subtype. This was a very interesting, we can criticize that it's only one study, but this really needs to be reopened and rechecked. And here again, the overall survival, the delta is much higher for the triple negative, yet it's still present. There is a survival benefit in the luminal subtype with dose-dense AC. So dose-dense AC is the cornerstone. We are not going to discuss any more about that. It's the best treatment for triple-negative subtype. What about other adds-on? Platinum, addition of platinum in a neoadjuvant setting. So platinum have been studied many years, and we had a lot of conflicting studies between positivity and negativity of platinum until in the ESMO, I think Fatma Abu Naga today have shown you this curve, which is the event-free survival for the addition of platinum. Look at the curve. There is a big difference between addition of platinum versus no platinum. So platinum in the triple-negative breast cancer have been finally released in the ESMO 2021 as an additive, and not only in the BRCA mutated subtype like we used to think. Look here, this is a BRCA wild subtype. And why? Because even if she is BRCA negative, we might have some BRCA associated genes which are working with BRCA, which are positive. You know, there is the genetic and there is the familial breast cancer. In triple negative breast cancer, BRCA is not the only counterpart which is hitting the same target. So we have some other genes here, and what we can see clearly that even in the BRCA wild triple negative, platinum in the green curve did add to the pathological CR. And yet, another and a last add-on, which is the addition of immunotherapy. And you know that immunotherapy have added and had evaded the landscape of breast cancer, and starting with the triple negative. So we have a star which is born in triple negative. And why specifically we choose triple negative? Why we did not choose the luminal? Because the rationale for that was that we have in triple negative breast cancer, in comparison with the other subtypes, a high mutational burden in comparison with the others, a high rate of TILs, tumor infiltrating lymphocytes, and a higher rate of PDL expression. If you check the PDL expression in the early breast cancer, in triple negative, it's completely different from metastatic setting. We have a much higher incidence of PDL in the early setting, we have a much higher incidence of tumor-infiltrating lymphocytes in the early setting, which is enhancing the response for immunotherapy in an early setting rather than in a metastatic setting. So KEYNOTE was the first trial, and KEYNOTE, as you all know, was the first published and approved trial in early breast cancer triple negative. And it was the experimental arm was the addition of pembro, and the control arm was the classic, what we give to our patient every day, with two primary endpoints: the pathological CR, which is what we need to reach for the patient, and the event-free survival. Of course, you know the eligibility criteria, and I think that one of the most important exclusion eligibility criteria is stage 1. I can discuss with Professor Sardauni about a patient which is less than 20 millimeter breast cancer. We don't need to give immunotherapy. These patients are cured with an upfront surgery and chemo. They have an excellent event-free survival, overall survival. So we have a lot of discussion. Oh, this is a triple negative breast cancer. We shall go for neoadjuvant. In stage 1, you might refer your patient, and they have an excellent cure rate with upfront surgery followed by immunotherapy. You don't need to go for a neoadjuvant setting. But, and the baseline characteristic of this study was very interesting, extremely well balanced. But look here, this is an important issue. Look at the rate of PDL positivity in comparison with the PDL negativity. We have 83 PDL positive. Look at the KEYNOTE 355 in the metastatic. You won't find this high rate of PDL positivity. It's much lower, it's getting lower, because in the metastatic setting, it's a completely different tumor microenvironment than in the early setting. So let's go for our primary endpoint, which is a pathological CR. That's what we need to reach. In early breast cancer, I have a question for the medical oncologist in the art. Is PDL1 prognostic or predictive? Who says prognostic? And who says predictive? Okay, prognostic. So let's see this. This is the chemotherapy and the immunotherapy devoid arm. These are chemotherapy, and these are different PDL expression in the tumor microenvironment. Look at the left side. The response rate for chemo alone is much lower in the PDL negative rather than in the PDL positive. Here we are talking chemo, we're not talking immunotherapy. So it's prognostic. The low PDL have a lower response rate and a higher incidence of relapse rather than the PDL positive. So the first question, is it prognostic? Yes, it's prognostic. But the second question is it predictive for the response to immunotherapy? Would it predict your response to immunotherapy? The PDL negative, would it have a lower response to immunotherapy? Look at the curve with the addition of immunotherapy. It did not predict. It did not predict. It was just a prognostic factor. So the delta in the PDL high versus the delta in the PDL low is almost as equivalent. Even you might find a better delta in the event-free survival later on for the PDL negative. So it's prognostic, it's not predictive. And the same data came from Nadia Harbeck from the IMpassion with the Atezo in a neoadjuvant setting. Chemo have a lower response in the PDL, it's prognostic, yet addition of immuno did not differ between the PDL negative and the PDL positive. So in early breast cancer, the PDL expression predict a lower response for the chemo, but it did not predict the lack of benefit for the immunotherapy. And why? Why the PDL did not predict response? Why? Why in early breast cancer it did not, and in metastatic it did? Because look here at in the preclinical trials, look at the value of the tumor-infiltrating lymphocyte in an early breast cancer. Much, much, much higher. Look at the metastatic setting. A big difference. Tumor-infiltrating lymphocyte enhance the response for immunotherapy. You have almost a 39% high incidence of tumor-infiltrating lymphocyte in an early setting, 6% in a metastatic setting. So that's what we call, in the metastatic setting, an immune-deprived microenvironment. And look at the PD-L1. The PD-L1 is much higher in the early rather than in the metastatic. And all this explain why we have a much better response for immunotherapy in all subtype of early versus that in the metastatic setting, we need the PD-L1 to be more than 10%. The second endpoint, which is the event-free survival, you can see that the event-free survival is definitely in favor of the immuno rather than the chemo alone. And you can see a magnificent hazard ratio of 0.63, 37 risk reduction of event-free survival. But look at this. This is very important in subgroup analysis. The delta for the PDL positive for immuno is 6.6. What in the PDL negative? It's much higher, 16. So if you have a patient PDL negative, the delta for the event-free survival is higher, which is something that we need to clear up for all of us. In all of our mind, the benefit for the delta for the PCR, the benefit for the event-free survival is higher for the PDL negative rather than the PDL positive, in this, despite the fact that this is not applied in metastatic setting. And you can see that the 3-year event-free survival for the PDL positive year is 85 versus 78 for the positive, 80 versus 63, extremely low without immunotherapy in the PDL negative. So the value is present for the PDL positive and the PDL negative. And that's exactly what we need to achieve. And if you can see the CR rate versus the non-PCR for the Pembro arm versus the control arm on the right side. And if you apply all the curve together, you can see that the PCR in both arms, in the control arm and in the experimental arm, have been almost the same. So the problem will be with the non-PCR. The patient not receiving immuno have a much worse event-free survival in comparison with those receiving immuno in the non-PCR arm. So the question will be, you know that in the keynote, we have to give immuno for almost to complete a year. So is it important? I mean, they achieved already a PCR, they are cured. So we have now what we call the optimized trial. The optimized trial is patient achieving PCR following Pembro neoadjuvant, either to receive placebo versus pembrolizumab. And I think that the optimized will show to us that you don't need to give extra Pembro for your patient following treatment. The safety summary, as you can see, the adverse event was higher in the experimental arm, yet patient who had a full exposure versus patient who have a discontinuation of the immuno had the same magnitude of delta. So initiating immunotherapy and stopping it did not hamper what we call the response rate and the pathological CR in both subgroups, because you have already an activated immune system. The secondary endpoint, which is the overall survival, was non-statistically significant, yet with longer follow-up, we might reach the overall survival. So the current approach now for triple-negative early breast cancer is that carboplatin paclitaxel followed by AC plus Pembro is the standard of care. Adjuvant Pembro to complete 1 year now is the standard until the optimized trial, but we have remaining question. And if you are an expert medical oncology in breast cancer, you will ask, what is the need of carbo in the era of immunotherapy? Do we still need those dense AC in spite of, well, just give me 3 more minutes and I will just finish. Okay. So will we need those dense AC? Will we need adjuvant olaparib in combination with immunotherapy? Will we need adjuvant capecitabine? All are these questions. The CREATE-X had clearly revealed an adjuvant improvement for the non-PCR patient. You can see the blue curve with capecitabine versus the control, but the combination of immuno, if you want to combine immuno in an adjuvant setting with capecitabine, you have a very high rate of diarrhea and hand and foot syndrome. So this is not a very friendly discussion. The PARP inhibitor, we know all of us about the non-PCR patient in the Olympiad patient, but can we combine immunotherapy with PARP inhibitor? We have data from the ovarian cancer with the Mediola trial. We have safety data from olaparib plus durvalumab. So how can we integrate and how can we design, if we have a project in triple-negative breast cancer and you want to check for all this question, I would say for the non-PCR, you would stratify patient to 3 subtypes. One, to give capecitabine, olaparib in a second row for germline, BRCA mutated, or pembrolizumab and check. This is a very logical study design. But if you need a better and a more advanced study design, so I would say for the non-PCR, like if you know all of us, the Catherine trial with the ADC for the non-PCR and HER2 positive, I would suggest an ADC for the non-PCR like sacituzumab govitecan. I think Ahmed Al-Dabawi today have shown you the data. This would be a very interesting trial of sacituzumab in an adjuvant for a non-PCR patient, or even what we call the new standard now, which is antibody drug conjugate plus immunotherapy versus pembrolizumab, which is a classic. So these are potential future trial that we can think. But my summary and my final slide is that yet in 2023, neoadjuvant pembro plus chemotherapy followed by adjuvant pembro showed a real statistical improvement and a meaningful improvement in event-free survival compared with chemotherapy alone without immunotherapy. The safety data of the Keynote 522 have been well known with no new safety concern, and Keynote 522 is yet the first approved immune trial meeting an unmet need in a bad disease, early triple-negative breast cancer, a challenging disease subtype. Thank you very much.
Thank you so much. That was a fabulous talk. Really interesting concepts, so beautifully explained. I will take away from this the different surrounding tissue and reactors in primary and metastatic disease. But I will also take away that PD-L1 is not that helpful in deciding your next steps in management, and particularly its expression in the primary when you're presented with metastatic disease. What do you think is going to be the future in terms of biopsying metastatic disease to help you make these really challenging decisions as to what would be your next line of treatment?
Sarah, first I would like to thank you. You're a surgeon and you're asking a very deep question in the medical oncology. Well, I guess that one day we will reach a better selection. It's not only about PD-L1. As you can know, all of you, the medical oncologists, PD-L1 is very important in metastatic breast cancer because we have an immunodeprived, we have very low TILs, we have extremely exhausted immune system in the tumor microenvironment in the metastatic. But one day we will reach what we call a molecular inflamed signature. What is a molecular inflamed signature? It's a signature which is giving all the molecular, the molecular subtype which would respond to immunotherapy. You know that now we have some negative subtype like the STK11, like the KEAP1, like the RAS. All these genes are against the use of immunotherapy, and we have some other tumor mutational burden, the tumor infiltrating lymphocyte. So this would come as a signature to check who is going to more benefit from immuno versus them who are not going to benefit from immuno. It will not only be the PD-L1.
Now it's my pleasure to introduce Dr. Ghada Samir from Tanta Center Cancer. The topic will be systemic therapy following first-line CDK4/6 inhibitors in advanced hormone receptor positive HER2 negative breast cancer.
First of all, I'd like to thank the organizing committee for inviting me for this talk. My topic today will be systemic therapy following first-line CDK4/6 inhibitors in advanced hormone receptor positive HER2 negative breast cancer. My agenda for today will be introduction, mechanisms of resistance, treatment strategies, ISMO guidelines, NCCN guidelines, then take-home message. Introduction: the hormone receptor positive HER2 negative subtype comprise 68% of all breast cancers. Endocrine therapy with CDK4/6 inhibitor is currently the standard treatment for hormone receptor positive HER2 negative advanced breast cancer, with a demonstration of overall survival benefit in several trials. However, treatment resistance inevitably ensues, and the optimal management after prior CDK4/6 inhibitor plus endocrine therapy continue to be refined. Tumor and/or liquid biopsy upon relapse or progression to determine the latest hormone receptor and HER2 status, as well as genomic profile, may provide insight into the underlying resistant mechanisms and allow an individualized approach to treatment. And now, what is the mechanisms of resistance? Mechanisms of resistance may be aberration affecting cell cycle progression, such as upregulation of CDK6, for example. Number two, activation of PI3K, ACT, mTOR, and mitogen-activated protein kinase pathway can be affected. Also, HER2 activating mutation can lead to signaling through alternative oncogenic pathways. Primary or secondary resistance to endocrine therapy backbone can occur concurrently. And now this is mTOR signaling pathway. In this pathway, growth factor binds to receptor, resulting in dimerization. Phosphorylation of the receptor activates downstream signaling through PI3K and ACT. PI3 ACT activation directly phosphorylates mTOR and the mTOR trigger. The phosphorylation of specific protein results in cell metabolism, cell proliferation, and angiogenesis. What is the treatment strategies? First strategy is targeting estrogen receptor pathway. ESR1 activating mutation at ligand binding domain of ER are rare in untreated primary breast cancer, but are typically enriched after exposure to aromatase inhibitor, with a prevalence of 20 to 40% in pre-treated advanced breast cancer. And this shows how, with advanced with the disease, ESR1 mutation increase. It's 0% during the adjuvant phase. In relapse, it is 5.3%. Upon progression, it is 33%. Fulvestrant is a pure ER antagonist and the only clinically approved selective estrogen receptor degrader until recently. Not only reduced ER dimerization and the transcription, but also induce ER degradation via proteasome-dependent system. Fulvestrant is superior to aromatase inhibitor in presence of ESR1 mutations. Results from randomized trials on several novel selective estrogen receptor degraders were recently presented. Elacestrant demonstrates a significant progression-free survival over physician choice of endocrine therapy, fulvestrant or aromatase inhibitor, in open-label randomized phase 3 Emerald trial, where patient had progressed after 1 or 2 lines of endocrine therapy for hormone receptor positive HER2 negative advanced breast cancer, including prior CDK4/6 inhibitor and maximum of 1 palliative chemotherapy. And this article was published in Journal of Clinical Oncology at October 2022. And 12 months progression-free survival in elacestrant arm was 22%, while standard of care was only 9.4%. Other strategy is targeting PI3K ACT mTOR pathway. In hormone receptor positive HER2 negative advanced breast cancer, the prevalence of activating PIK3CA mutations is estimated at 30 to 40%. PIK3CA mutated hormone receptor positive HER2 negative breast cancer have also been seen associated with inferior survival outcome compared to wild type tumors. And this is SOLAR-1 phase 3 randomized controlled trial with 2 cohorts, PIK3CA mutant cohort and PIK non-mutant cohort, and each cohort is randomized either to zifalbilasib plus fulvestrant or placebo plus fulvestrant, and primary endpoint was progression-free survival in PIK3CA mutant cohort, and secondary endpoint was overall survival in both cohorts, and progression-free survival in non-mutant cohort, overall response rate and safety. And this is a primary progression-free survival in PIK 3CA mutant cohort. Median was 11 months in alpelisib fulvestrant arm, while it is 5.7 in placebo arm, with a significant p-value. Proof of concept criteria were not met in PIX3CA non-mutant cohort. mTOR inhibitors. Although everolimus trials were conducted in pre-CDK4/6 inhibitor era, mTOR inhibition remain a valid treatment option for patients regardless of PIX3CA mutation status. The phase 2 Belrose study compared everolimus and exemestane versus exemestane and placebo in patients with advanced hormone receptor positive HER2-negative breast cancer who suffered from disease recurrence or progression after while receiving non-steroidal aromatase inhibitors. And this is the design of the trial. And primary endpoint was progression-free survival. Secondary endpoint was overall survival, overall response rate, clinical benefit rate, and quality of life. And the median progression-free survival, everolimus exemestane arm was 11 months. In placebo arm, it is 4.1 months with a significant p-value and a hazard ratio of 0.3 with a good separation between the two curves. The question now, can we continue CDK4/6 inhibitors beyond the progression? Let's see. And this is a maintained trial, randomized phase 2 trial of endocrine therapy with or without ribociclib after progression on CDK4/6 inhibitor in hormone receptor positive HER2-negative breast cancer, metastatic breast cancer. And in which patient, who progressed on endocrine therapy plus any CDK4/6 inhibitor and less than or equal to 1 line of chemotherapy were randomized either to receive ribociclib plus placebo with fulvestrant or exemestane. In terms of prior CDK4/6 inhibition, 87% has received palbociclib. In intention to treat population, median progression-free survival was 5.2 months in ribociclib arm compared to 2.7 months in the placebo arm with significant p-value. The data seems to show a possible benefit of switching from one CDK4/6 inhibitor to another versus re-exposure to the same treatment. While these results suggest benefit from ribociclib, a confirmatory phase 3 trial is essential before this strategy is adopted as a routine clinical practice. One of the strategies is targeting cancer epithelial antigen via antibody drug conjugate. The positive results of phase 3 Destiny Breast 04 led to FDA approval of trastuzumab deruxtecan in August 2022 in treatment of HER2-low advanced breast cancer in patients who have received prior chemotherapy in the metastatic setting or developed disease recurrence during or within 6 months of completed chemotherapy. And this was published in New England Journal of Medicine. The patient was randomized with HER2-low advanced breast cancer to receive trastuzumab deruxtecan versus the physician's choice of chemotherapy. Subjects with hormone receptor positive, HER2-negative, low advanced breast cancer has received a median of 3 lines of prior palliative therapy with prior CDK4/6 inhibitor in about 70% of the cohort. The primary endpoint was of progression-free survival. Median was 10.1 months versus 5.4 months, and overall survival improvement as well, 23.9 months versus 17.9 months. And this is TROPICS-02 trial, overall survival with trastuzumab govitecan in hormone receptor positive HER2-negative metastatic breast cancer. And this is the design of the trial, with primary endpoint was progression-free survival, overall response rate, secondary endpoint was overall survival and duration of remission. Results showed progression-free survival and overall survival improvement with trastuzumab govitecan over the patient's choice of chemotherapy. Median progression-free survival was 5.5 months versus 4 months. These data support trastuzumab govitecan as a new treatment for patients with pre-treated endocrine-resistant hormone receptor positive HER2-negative metastatic breast cancer. And one of the strategies is targeting the homologous recombination repair pathway. BRCA1 and 2 tumor suppressor genes are involved in the homologous recombination repair pathway. Hormone receptor positive breast cancer arising in germline BRCA mutation carriers frequently exhibit genomic instability with higher histological grade than the oncotype DX recurrence score than sporadic tumors. Real-world studies have reported inferior progression-free survival and overall survival on endocrine therapy with CDK4/6 inhibitors in patients with germline BRCA mutation. PARP inhibition may lead to synthetic lethality in these cells. Olaparib and lazoparib are approved for the use in patients with germline BRCA mutation and HER2 negative advanced breast cancer in post-chemotherapy setting following Olympiads and in BRCA trials, which demonstrate the progression-free survival over physician choice of chemotherapy. Hormone receptor positive HER2 negative patient accounts for around half of the population in both trials. And this is the Olympiad study design. And patient was randomized either to receive olaparib or chemotherapy until this progression on unacceptable adverse events. Primary endpoint was progression-free survival. Secondary endpoint was time to second progression, overall survival, overall response rate, safety, and tolerability. And median progression-free survival was 7 months in olaparib arm versus 4.2 in chemotherapy. Now, what NCCN guidelines recommend? It recommends after progression, after CDK4/6 inhibitor, PI3K inhibitor, everolimus emitter inhibitor plus endocrine therapy, fulvestrant or elacestrant in ESR1 mutation, also a combo of hormonal treatment, non-steroidal plus fulvestrant. And in case of visceral crisis or endocrine refractory chemotherapy, if no germline BRCA mutation, if there is germline BRCA mutation, PARP inhibitors in HER2 low, famtrastuzumab, deruxtecan, are not candidate for this, filgrastim, govitecan, or systemic chemotherapy or targeted therapy according to positivity of biomarker. And now what is ISMO's guidelines? After CDK4/6 inhibitor progression, if imminent organ failure, their chemotherapy, if HER2 low, trastuzumab deruxtecan. If no imminent organ failure, there is no visceral crisis, everolimus exemestane, everolimus fulvestrant, switch endocrine therapy plus or minus CDK4/6 inhibitor, fulvestrant monotherapy, if PIK3CA mutation, fulvestrant alpelisib, if ESR1 mutation, elacestrant, if germline BRCA mutation, PARP inhibitors. And on progression, if HER2 negative, trastuzumab govitecan, if HER2 low, trastuzumab deruxtecan, and furthermore on chemotherapy. Take home message. Endocrine therapy with CDK4/6 inhibitors is currently the standard treatment for hormone receptor positive HER2 negative advanced breast cancer. After progression on CDK4/6 inhibitor therapy, no standard of care exists for the next line of systemic therapy. Reasonable options include switching to another endocrine monotherapy, fulvestrant or elacestrant, is superior to aromatase inhibitor in presence of ESR1 mutations, cytotoxic chemotherapy, endocrine therapy with everolimus M2 inhibitor, talazoparib or olaparib, PARP inhibitors for patients with germline BRCA mutations, or alpelisib PI3K inhibitor for patients with the somatic PIK3CA mutations. Whether or not CDK4/6 inhibitor should be continued after initial disease progression is currently unknown. A confirmatory phase 3 trial is essential. Sacituzumab govitecan is the new treatment option for patients with pre-treated endocrine-resistant hormone receptor positive HER2 negative metastatic breast cancer. Trastuzumab deruxtecan is approved for treatment of HER2 low advanced breast cancer in patients who have received prior chemotherapy in the metastatic setting. In an attempt to help to fill this knowledge gap, we must analyze real-world data to determine what systemic therapies were being used following progression on a CDK4/6 inhibitor and compare differences in progression-free survival and overall survival between the different treatments. And thank you.
I'd like to present next Dr. Hagar El-Ghazawi in Ain Shams University, Professor of Oncology, Medical Oncology, Ain Shams University. She will be presenting management of regional lymph nodes in breast cancer, debates and updates.
Myself and my colleague, Dr. Sharif Hassani, and I'm pleased that my lecture is complementing your views after the de-escalation of breast surgery and your insights for that. My lecture will discuss the de-escalation of the regional lymph node management in breast cancer. Actually, we always face in the MDT everyday practice that are some questions, debatable questions. We all have some time with the surgeons and radiation oncologists and medical oncologists to discuss with no available high-level evidence in a specific situation. So we have to have some discussions. We have in the treatment of the axilla, the upfront setting, the neoadjuvant setting, and if we can omit any axillary management. In the upfront setting, we have some questions regarding those with the Z11 criteria. If mastectomy was done, can we omit the axillary lymph node dissection? And if there is sentinel lymph node positive micrometastasis, and what we can do if there are more than 3 sentinel lymph node positive, 3 or more. Can we omit the axillary lymph node dissection going parallel with the Z11 and the AMARYS trial or not? In the neoadjuvant setting, what about the downstaging of the axilla from clinical N1 or N2 and 3 to the clinical N0 situation to go for the sentinel lymph node biopsy instead of the axillary lymph node dissection? Although another question, what about those with clinically node positive who attain PCR? Can we omit the regional lymph node radiation or not? This is very crucial in the medical or the clinical oncology perspective. And as we said, if there is any situation, can we omit the sentinel lymph node and axillary lymph node dissection and the radiation when in this situation? So to have a refresher, we all know that the level 1 axilla, level 1 lymph node, level 2, level 3 are related to the pectoralis minor, either lateral, level 1, to the lateral border, the level 2 behind the pectoralis minor, and level 3 is lateral and superior. So we all know that level 1 and 2 mostly included in the breast tangents, in the normal breast tangent, while level 3 is not. Another piece of information we have to know that the risk of lymph node metastasis are proportional with the tumor size. So even tumor size T1 have a proportional risk to have a risk of lymph node metastasis, T2 approaching the 40% to have a lymph node metastasis, and this increased largely with T3 and T4. Also, we have to know that clinically node negative and undergoing sentinel lymph node biopsy, this piece of information from the well-known trial NSBP 32, that they may have 30% of having a sentinel lymph node biopsy positive. And going to the morbidity, the axillary lymph node dissection have a substantial risk for the lymphedema and pain and limited mobility. So going again to the evidence base, we have going with line, the timeline are for landmark de-escalation practice changing clinical trials, started with de-escalation of the axillary lymph node dissection and going for sentinel lymph node biopsy only for those with clinical node negative, then even those with sentinel lymph node biopsy to go for, sentinel lymph node positive to go only without the axillary lymph node dissection, then to de-escalate more and more for those clinical node positive in the neoadjuvant setting. The major 2 landmark trials, we start with the Z11. It included randomized patients with sentinel lymph node biopsy, 1 or 2 only, 2 axillary lymph node dissection versus no axillary lymph node dissection, those with upfront breast conservative surgery, and will be planned to post-operative radiation with no supraclavicular radiotherapy. The primary endpoint was the overall survival, the secondary endpoint was the disease-free survival, and the results after about 10 years of follow-up, the overall survival disease-free was non-significant. Also, the regional recurrence was 1.6 versus 3.1 in the axillary lymph node dissection versus those didn't receive axillary lymph node dissection. And of course, the lymphedema, paresthesia, pain were significantly higher in those with axillary lymph node dissection. So we concluded from this trial that the axillary lymph node dissection is not needed in the low disease burden, and in those with 1 or 2 lymph nodes, radiotherapy and sentinel lymph node are enough. An important caveat in this trial that mostly level 1 and 2 was covered by the radiotherapy in the no axillary lymph node field. I mean that those who didn't receive axillary lymph node dissection, they are not without treatment, they received radiotherapy, substantial dose of radiotherapy to the axilla. Also 50% in both arms received high TANGES, and to remember that this trial did not include patients with neoadjuvant treatment or clinical T3 or T4. Another landmark trial, the AMAROS trial, it included the patients also with sentinel lymph node biopsy positive to breast conservative or mastectomy, and randomized the patients between the axillary lymph node dissection and the radiotherapy. The primary endpoint was non-inferiority to the 5-year axillary recurrence, and secondary endpoint to the overall survival, disease-free survival. Also, again, the results were after 10 years of follow-up published last year. The axillary recurrence rate was 0.9 in the axillary lymph node dissection versus 1.8% in the radiotherapy arm, and no difference in the overall survival or the disease-free survival. And so, considering again the less arm morbidity or the side effects, so the axillary lymph node radiation is preferred over the dissection for those patients with sentinel lymph node biopsy, clinical T1, T2, and 0. So in practice, those patients, when we face in the MDT, those with sentinel lymph node biopsy 1 or 2, not 3, and didn't receive neoadjuvant chemotherapy, we should acknowledge that they have a low risk for axillary failure, 1 or 2%, so we can simply omit the axillary lymph node dissection and go for the sentinel alone, plus or minus with the axillary radiation, with or without the regional nodal radiation. So we have a question here for debate. If the patient is undergoing mastectomy, should we go for those trials and go per protocol to go to omit the axillary lymph node dissection and only the sentinel lymph node, or I must complete the axillary lymph node dissection? So we, as we said, that the Z11 did not include patients with mastectomy, and the AMAROS trial included about 17% of those patients. But there is no reason to believe that the efficacy of nodal radiation will vary upon the type of breast surgery. So in patients with mastectomy, this is according to the consensus on the overall total evidence available, that the patients with mastectomy who have indication for post-mastectomy radiation, both based on the presence of metastasis of 1 or 2 sentinel lymph node and primary tumor characteristics, I mean that the radiotherapy is planned anyway, so the axillary lymph node dissection can be avoided. And the axillary lymph node dissection is indicated when the need for the radiation is not clear. Some institutes and some guidelines that when mastectomy and 1 or 2 lymph nodes, you can omit the post-operative radiotherapy. So if you are not planning the patient for post-mastectomy radiotherapy, you will complete the axillary lymph node dissection, and this should be pre-planned with your MDT team. So here are the NCCN guidelines, and this is from the oldest versions. This is not new. When the patient is in the mastectomy line, so if she meets all the criteria for the Z11 and the AMAROS, and the last line, if she is planned anyway for the adjuvant radiotherapy, yes to all, you can consider no further axillary management. So the second question, if the patient had, the pathologist said that the sentinel lymph node is not a macrometastasis, it is micrometastasis, and this we face in the clinical life. Micrometastasis, I mean it is 2 millimeters or less. Should you go to the Z11 again and the AMAROS and complete your axillary lymph node dissection, or give the axillary radiotherapy or not? This trial was specifically to answer this question, and they randomized patients with micrometastasis to axillary lymph node dissection or no treatment. As expected, no overall survival or disease-free survival between the 2 arms, so you can safely omit any further treatment for those patients. So coming to the last question, if there are 3 lymph nodes positive in the sentinel lymph node, can we omit the axillary lymph node dissection? No, you can. You must complete, and no any supporting evidence for those with 3 lymph nodes or more. In another section, in patients who are treated or planned for the neoadjuvant treatment, The main caveat here is the patients who are clinical node positive and converted with the neoadjuvant therapy to clinical node negative. We have well documented in the studies that the false negative rate ranging between the 14% and 12%. So there are many technical factors to decrease these false negative rates, including the dual tracer and the localization and clipping of the positive lymph node before starting the neoadjuvant chemotherapy, or obtaining and retrieving 3 sentinel lymph nodes or more, and using the target axillary ultrasound after the neoadjuvant chemotherapy. In this well-known meta-analysis, you can see that the single mapping led to a false negative rate of about 19%, while dual mapping reduced the false negative rate to 11%. And on the other side, if retrieving only 1 lymph node, the false negative rate may reach 20%, and retrieving 3 or more positive lymph nodes will decrease the false negative rate to 4%. So here is the algorithm we follow and the recommended one. If you found after the neoadjuvant chemotherapy still positive or residual lymph nodes, you must go directly and complete the axillary lymph node dissection, whatever the residual size or burden. If there is no any residual in the sentinel lymph node negative, you can omit any further axillary dissection. So the common question we face frequently, if the patient was clinically N1 or N2 or N3, would it differ in the management or not? I mean, to go for sentinel or not? Actually, we have the data from the ASCO guidelines 2021, the MD Anderson guidelines, and the American Society of Breast Surgeons 2021. They all recommend that the patients only with clinical N1 to go for the de-escalation with chemotherapy, and if reached the clinical N0 to be de-escalated and make the sentinel lymph node biopsy. But those with clinical N2 and N3 at the initial staging, it is not preferred, and you must go for upfront axillary lymph node dissection and not to go for the sentinel lymph node biopsy. However, some guidelines, it is expert opinion, they may recommend the sentinel lymph node biopsy for those with clinical N2 and reached the clinical N0 after the neoadjuvant chemotherapy, but recommending and highlighting and underscoring the importance of the measures to be taken to decrease the false negative rate. The last question in the neoadjuvant setting, if the patient attained the PCR, would we, as a radiation oncologist, would we omit the regional radiation? Up till now, we have any answer for this question. If the patient attained PCR, it is a good news, but I cannot omit the regional radiotherapy until we are waiting all the results of this ongoing trial, the B51, well-known trial, randomizing the patients according N1 disease, receiving the neoadjuvant chemotherapy, randomized to regional radiation or not, and stratified according to PCR achieved or not. The third section for omitting the axillary management, we have many studies, but I will select the main important one and recently published, the SOUND trial, which evaluating patients with clinical T1, 2 centimeters, and 0 by ultrasound, receiving breast conservative surgery and radiotherapy to be randomized to sentinel lymph node versus no axillary surgery. After 5 years of follow-up, there was no difference in the locoregional recurrence or distant recurrence or the distant metastasis between the 2 arms, and this results was highly suggesting that the patients with these features can be safely spared any axillary surgery whenever the lack of pathological information does not affect your post-operative treatment. I mean, I do not want in this particular patient to know if it's pathological N1 or 1 lymph node or 2 or 3 that will impact my escalation of the adjuvant treatment in the adjuvant setting. In the ESMO 2023, few days ago, I will highlight to you a small note. They mentioned that it was in a very interesting session concerning the debate for the axillary management. This is Professor Peter Dubisky, he is a very well-known surgeon. He, in the neoadjuvant pathway, those with clinical N1 only, not N2 or N3, those with achieved pathological and positive after the neoadjuvant setting, we must know that the additional lymph nodes may reach 40%, so they recommend, and it's recommended, as I mentioned, axillary lymph node dissection. Don't go for the Z11 criteria anymore. And if it is sentinel lymph node negative, additional positive lymph nodes may reach more than 40%, so it is highly recommended the measures to decrease the false negative rate. Our take-home message is today that if the patient is clinical node negative and planned for upfront surgery and sentinel lymph node negative, no further axillary or nodal treatment. If upfront surgery and sentinel lymph node biopsy positive 1 or 2, no axillary lymph node dissection, with or without the axillary radiation. As we said before, 50% was included in the Z11 and the AMROS trial, plus or minus the regional nodal radiation. It includes many factors to be taken in consideration. And the upfront surgery and the patient retrieved 3 or more sentinel lymph nodes, she will go for axillary lymph node dissection with regional radiation. If the patient was planned with clinical node positive to neoadjuvant chemotherapy and converted to clinical node negative and sentinel lymph node negative, no further management will be moved to. And if clinical node negative, sentinel positive, will be planned for axillary lymph node dissection. And if still clinical node negative after chemo, she will be planned for axillary lymph node dissection. And thank you.
Thank you very much, Dr. Hopper, for your excellent presentation. Very informative and really clarified. Really clarified most of the situations during our surgeries for axillary management. Thank you very much. Any questions? Okay, thank you. Okay. Now we close session 1 and we'll begin session 2.